cloud.
These are the whole process of delivery?
Yeah, this is pretty much from interpartum is like the L&D process to the delivery of the placenta. And then after that, we go into postpartum. I'll go ahead and have it like this so we can kind of see the bottom stuff. Okay. In L&D, we have now 2 patients to worry about. And the backbone of it here. And this is when we are going to be talking about the ABCs do come into this, but we always are going to be also doing psychological safety. So it's about emotions and stuff like that as well. But pretty much today we're going to be like talking about stuff you're going to go over next week, which is the different P's of all the powers, and it'll be really cool. So that's not showing. This is also from last week as well. We have the different childbirth methods. And I think I actually have some practice questions on this. So it's like, I don't know, it's weird. These childbirth methods here, it makes so much sense. But then sometimes you get a question thrown at you and it could be difficult. So I'm going to try to get you guys prepared. I have some practice questions. But we did talk about this last week and we had kind of different ways to kind of talk about it. We went over them last week with the Lamaze, think about pattern breathing. We have our 2 A's there. We have the Bradley, that's going to be more of abdominal breathing. Hypnobirthing is all about going to be relaxation, things like that. Body conditioning, we actually can do Kegel exercises to prepare. That's kind of just getting your abdominal muscles going there. Because the labor process is very physically demanding, so you can get prepared and things like that as well. The Mick Roberts position, we have it highlighted here, is the when someone flexes their legs towards her shoulders while she's trying to lying on her back. This will be needed in the 2nd stage of labor. This stuff's not that important. Not too yet, actually. Okay, just stuff that we've kind of summarizing from what we've already done in exam 1. Ways to prepare for childbirth. It's all about prenatal care, knowing the different appointments and stuff like that. So pretty much if you're studying for the HESI, I would say this slide isn't that helpful. You would probably want to go back to exam 1 stuff when we're talking about how often are you going to those appointments, what is the proper nutrition, eat lots of iron, that acronym, that'll probably be on your HESI. So you might want to look over that before that goes. This screening and immunizations, we will go over again. And we have an actual exam 2 prep sheet doc that I would recommend you fill in by hand, but if you don't, it's okay. And we actually have an entire PowerPoint that we're going to go over that. Not today, but in the coming weeks. Okay, going into the stuff that is the backbone of everything with an L&D question, we do have the 4 P's of labor. And the first is going to be passageway. It's all about the pelvis. And if the body is allowing the space to go through, and it's all about passageway also goes into cervical dilation. Much of us are familiar with 0 to 10 centimeters, but it's not just that, it's also effacement. And when you see effacement, think of thinning. It will be 0 to 100%. With that, with passenger, that is going to be the baby. We do have an entire form of acronyms that we're going to go over that really talk about the fetal lie. And of course, Carol will be able to explain that a lot better, but fetal lie can range from being very complicated to very simple. Generous enough for the NCLEX, it's going to be pretty much always the simple stuff, but we have to be prepared for everything. And we'll go over that as well. Powers are going to be the actual contractions themselves. Today, we're going to go over what those different words mean whenever we're talking about frequency, duration, acme. And I'll show all this on later slides, so it's going to be okay. And then, of course, psychosocial considerations when we're talking about this. Yeah.
Sorry, did you really pull this?
Oh yeah. Later up. Okay. And this stuff's intro, so there's going to be slides that are more detailed than these already. Passageway here. We have different types of pelvises that are really favorable and some are not favorable. We do have the gynecoid, which is the most favorable. I would say highlight that one. And then we have the other ones as well that are just, they can vary in size and shape. But for us, I know you might have to just know what's the most. I mean, you're not going to like draw it out or anything like that. Then we have into the cervix, also called the neck of the uterus. We have these terms here. Effacement is thinning, of course. It goes from 0 to 100%. And when we're at 100%, this is when we're talking, it's paper thin. I always think of it like loading, it's loading, we're getting ready for the L&D process. Dilation, of course, 1 to 10 centimeters. And man, I have a little chart that you can practice with your fingers, but I left it at home today. I'll bring it next week. It's okay. I have the posterior and the anterior. When you're thinking of this, that's actually going to be, this is like the relation of the pelvis itself. So the posterior is, of course, going to be the backside, close to the pelvis, and the anterior is just going to be right there. We do have the softening. It's going to be, when it's firm, think about the term thinning again. As it's becoming softer, it is becoming closer as well. The Bishop score is really bringing all of these 4 things into consideration. So we do have, it's kind of a rating on, how ready are we going? So we have, if they are all zeros, we're not ready to have a baby. But if that score is high, then the baby is ready to come out. So you could potentially have a question describing these different things. It'll say maybe, we're at 5 centimeters, it's 50% effaced. I don't know if it would make you judge a Bishop score. I think Harold would probably tell you that in class on Monday, but you could potentially have it where it's like, this is the Bishop score. What does this kind of mean? And this could be the definition, So all zeros, it's a no-go. But the higher the score is, the more things are ready. Passenger, here we go. We have the fetal lie. This is all about the spine. Typically, we want these things to be parallel when we're going into, just think about the process. Going down, you wouldn't want to have the baby parallel compared to our spine. It just doesn't naturally work out. So thankfully, though, they can move before they are engaged. We have the fetal attitude, how the head is in there. Mostly the head is going to be flexed. So when we're thinking flex, we're thinking, kind of like a bicep, it's flexed, and the head will be down towards its chest. Typically, you could have different positions that you guys will go over Monday, and maybe in this as well, but the flexion will allow it to, feel a little smaller, and it allows normal ability to kind of slide down the pelvis. But we could potentially run into complications when we have the head that is extended, which is where it will be, extended kind of towards your back. Or it could be like a military stance where it's just straight vertical. The presentation is whatever comes first. When we're thinking presentation, it's like the presenting part. That's what they're usually going to say on a question. The presenting part is usually going to be our head, but sometimes it's the foot. And we're going to the foot, that's when we're going to like, essentially we could be worrying about maybe a protruding umbilical cord, because it's just kind of like that. Then a breech delivery. The position is the relationship of that to the maternal pelvis. We've already said the word engagement, but engagement is whenever we are at, that's like the tightest it will ever be. The largest diameter breaches the pelvis. and it can be delivered by vaginal examination. Station is the numbers. It's going to be, well, I don't have the whiteboard here, but it'll be like it'll be +3 or -3. And then when it's engaged, it's going to be 0. But pretty much the word that we always like to say is +4 on the floor. So if the baby's at, think of it like a line, and it's negative and positive. And if it's negative, it is not engaged and it is more still inside. But as it comes closer, you know, sometimes you'll see on questions where we're talking, you know, the fetus is at a -3 lie, and then within 30 minutes, it's +1. You know, it just gives you an image. That's always going to be in centimeters. And then EFW will always be estimated fetal weight from here kind of on out. Fetal lie. Ideally, we want to be parallel. We have this picture here. You know, just think about it. That is perpendicular to the body, and we want everything to be lined up. We want both spines to be going together. If this would happen, the baby wouldn't fit in the birth canal, uterus will still contract, something will finally give way, and that's usually going to be the uterine rupture. I know when I first ever saw this stuff, I was like, wow, the actual stomach ruptures. No, it's just the uterus itself. That's when we can have lots of different bleeding and stuff like that. We do have a few terms here. We have the breech birth. That is where the buttocks come first. The butt is coming first. It can be frank. It can be shoulder and footling. And I believe I have pictures coming up for that. If not, actually, I'll just pull up here. Breech. Okay, so we have these kind of different things here. So notice how the butt is first with all of them, but when we're talking about the different words, it's really talking about the way the feet are. I really like those pictures. When we're thinking about a incomplete breech, always kind of look at the feet. With the frank, the feet are going to be up. With the complete breech, I always kind of picture it as their feet are tucked in, and it looks like they're kind of kicking out a little bit. But with the frank breech, they're both up, and incomplete, it's one or the other. So with the frank, I don't know, up like a little peanut, all cute. But with complete, they're completely just kicking against the bottom in a way. They can actually feel, they can palpate, but it can be confirmed by ultrasound. And kind of I would be scared with this stuff, but thankfully we have a lot of prevention staff to really catch this stuff early. Sometimes these, with the word engagement, sometimes they're not engaged yet. So it's they're starting out as a breech, but once they get engaged, things can be a little bit better. If it's really bad, they'll usually do a C-section.
So engagement is just another word for dilating?
Engagement is it's, how would I explain it? Think of it as the fetus is descending. And once you're engaged, you can't go back up anymore. It's all about descent from there. So we have the spine and we have the pelvis. And once it's kind of past that area, it's pretty much whatever you're in, it's engaged rather. It's all about coming out in that same position. If the patient gets engaged with a frank breech, it's gone through the pelvis and it's just gonna have to be that way. But pretty much before you're engaged, the baby can still change position, it can rotate, things like that. So I guess that's the way to kind of think about it. Okay. The fetal attitude is all about the head. Normal attitude is flexion of the neck. Everything's kind of tucked in all pretty. But notice, I mean, just this picture here, if this head is, you know, extended back, the entire space it's taking up is just more, where it's all about taking as much limited space as we can. But whenever they're extension, it's just larger because you're going from the feet to this side, like the head will be over here. And that's just, extension has the biggest diameter of it itself. This picture here is full flexion. You know how it's going towards the chest, bringing it forward. And it's very minimalistic. It's, you know, all about conserving that space. It's a lot of vocabulary. And I do apologize. It can be a bit overwhelming, but the more you kind of get exposed to it, it'll help a lot more. I don't know, weird terms like thinking of the flexion as, you know, just muscles and it's bringing it up or something. That's the way, I don't know. We have the presentation here. We have some different ones, but remember with the breech, it's the butt first. We have the frank breech with the butt first. We have these terms here that are going to be newer to us. Syncopate is where the head's partially flexed, so it's partially coming forward. The shoulder, if we have a shoulder presentation, that means that the shoulder is the first presenting part, which means the first part you see whenever you're doing an assessment would be the shoulder. You could have a brow, which is the head. It's the front of the head. Think of your eyebrows kind of near there. We could have a footling breech. It can be one or the other. And then a full breech, which is where you're when you kind of go to, when it's descending, it's the thighs that are coming towards you in a way. We have these pictures here. And I pulled these from textbook, so pretty cool. A would be a frank breech because it's the thighs coming first. And B here would be a complete breech because it's kind of like kicking out the walls in a way. Can you kind of see it? Does it make a little sense? I don't know. Okay, we have different breeches here. A single footling breech, it's in the word, one foot is coming forward. And the double footling breech, I mean, just this is, you can kind of see it here, but this is a lot different than this. I mean, the head's coming forward on this, it's fully flexed, and then this is just feet are coming first. I mean, coming to the pelvis, it's a lot more space it's taking up. So this is why we just kind of observe this thing. But we do a lot of things to prevent this. We have to learn it all complications and also. Fetal presentation, I would say this is the part that people don't like the most because it does, it can be a little confusing, but thankfully exam 2 review does have a diagram. And I would say submit it early for Harold whenever you guys get that. Not the day before the test, because I would say if you guys can get the ability to have your stuff kind of looked over, because she really does look over your exam 2 prep assignments, and if there's something that you have wrong, she'll fix it on there, and she'll kind of put a really good connotation of what it was supposed to be. I remember when I took this class, a lot of us kind of had this wrong on our prep assignment, and it didn't really go good for when this was tested on. So I would say get it confirmed. It starts out making a lot of sense, but I mean, with proper pictures and just always using your textbook and using pictures on Google can kind of help you evaluate this. We have the most common here, which would be very helpful if that was under NCLEX. But the first letter is obviously right or left. It's telling us which side of the pelvis the presenting part is toward. The second letter will be the landmark. The landmark is either going to be the accompanying process. It's going to be the mentum. So the kind of chin, I always put in the italics, kind of my verbiage of it, but the occiput is the vertex. It's kind of the lower back of the head. Occiput is the most common. So as we go to the picture up here, this was an occiput presentation. It's the back of the head that's first coming out. The mentum is going to be the chin. So just imagine if the baby was kind of extending a little bit and the chin was the first part, or that kind of breach rather. And the accompanying process is going to be the guiding point for a shoulder presentation. And it's always going to be these three letters here. It's just different interpretation. It's going to be like a ROA, and occiput. Of course, the back of the head is the most common, but it can always vary. And we have the pictures here to kind of support that. Occiput is the back of the head. We have the mentum is kind of around your chin. Vertex. Of course, we have these different fontanelles. Those soft spots that can really bend, and they're very like, they're not closed until after birth to kind of help things out a little bit.
Occiput is tucked into the chest, right? Into the chest.
Yes. Yeah, the occiput is the back of the head. So in an occiput presentation, they're kind of flex, their bodies flex like this, and their head is typically towards their chest. We're probably going to be going back to that picture a lot. And this is the table here. But it's like, I think on your exam 2 prep, we're going to have where you kind of evaluate these letters, and it's just, you know, what are the letters kind of meaning here? And I'll pull up some pictures. I think right here, this can help a little bit. Try to zoom it in. Oh no. I don't know what I did. Okay, I'll just go back to it at the end of the session and we'll kind of talk about it a little bit more.
I think if you lower the note on
Here?
the notes, like
Oh, yeah. And I guess just for this slide, I'll do it right here. So we have the first letters L and R, kind of looking at where the presenting part is. You see up, and we're always talking about from our interpretation, looking at the mother. Okay, so if they're facing us, you see how it's going to the left on that left occiput anterior, and then whenever it's coming, like for example, on the next one, it's transverse, but it's not saying that the body's actually in the transverse. I can't really recall the correct verbiage of that, but you know, this will make up barely any of your tests, but I'll be sure to like type up some really cool stuff to memorize that. But when we're going into the lies, it's just a little bit, I guess this is a lot different here on the bottom, but we have the brows, we have the transverse lie itself. It's just, you might have to go back to this picture whenever it comes to doing that exam prep sheet as well.
The ones on the bottom are like C-section, like those would be like emergencies.
Yeah, just how it's not fitting. These are our breech presentations.
So also, because
Yeah, you with like from the outside, you like before they're engaged, you can like some really strong palpation and stuff like that. Right. Going a little bit more. Yeah.
Is it not by like, when it says like left transverse, is it not by like the interior position, like?
Yeah, it's from us looking at them, I guess. So like if you were looking at me, like I guess it is flipped because you'd be saying left, but it's actually my right. Yeah. Yeah, you're looking at them. Oh, it's so confusing. It is very scary. I know in the NCLEX prep we did of this with Mark Klimek, it was like if you're getting these questions, that means you already passed NCLEX because those are the really hard ones. So it was really cool. Fetal station, we've already talked about this. Oh, I'll pull it back like that. But we do have like kind of what we drew here already. Negative means it's still inside. Once we get to plus, it's, you know, centimeters below. And it's rather coming as well. Once we get to the 0 here, the reason we always say it's kind of, I guess it's like engaged and stuff is because where it's at 0, see how it's the narrowest part at the ischial spines. That's kind of why we always use that as the, like, I guess, verbiage of that, because if the baby's still in negative, and it hasn't passed 0, then we're still thinking like this could still maybe be a C-section, different things like that. But once we're in kind of the plus, it's already past the thinnest or the most narrow process. So it's pretty much just, it's all coming from there. But going into the powers, we have, these are very important terms. This you could potentially have a fill in the blank on any of these words. And really just, I would say, I can't stress this enough. These words here, they're rather, I guess just once you kind of get it in your head, it's a lot easier, but the actual word acme, of course, means peak. Increment is always about that building up. And I'll keep going back to this a lot over here. Here's the picture of this. So this is our contractions here. Whenever we're talking about the frequency, this is about, how often is it? But the term frequency is the time in seconds measured from the beginning of one to the beginning of the next. So we have the beginning of this first one. You would sometimes on a test, you might get it where it's like, it's the beginning of the first one to the end of the first one. No, that's duration, but when we're talking about how often it's coming, it's really how often are they starting? See how it goes from the beginning here to the beginning of the next. When it's duration, we're talking about how long are these. So that's why it's going to be, the duration will be the beginning of one to the end of one. The increment is that, think of it like a roller coaster. It's going up, it's the building up phase. The peak is the very peak. The acme is what it's called. And then when it's decrement, that's always the kind of letting up, it's decreasing. And then the niter is going to be just the resting phase. It's the period between right here. But this picture to kind of puts a lot more into perspective here. It's the frequency is how often are they coming, duration, how long is each contraction, increments, the building up, we have the acme, the peak, the decrement, and the resting period. Okay. Psyche, of course, comfort. They could have fear, pain, excitement. How does this kind of affect our labor? You'll find that usually before, in the stages of labor, and we'll talk about this in a little bit, but in the first beginning, they're all excited. It's very relaxing, but it's usually once we're getting to that first stage of labor that's really like the active phase of it, where it's a lot of the dilation is really occurring. That's whenever it gets a lot more, I guess, emotional, painful, the feeling of loss of control, feeling ill-prepared, things like that. But we have a lot of preventions, and we have breathing exercise and something that can kind of work with that. If these patients have a lack of knowledge and preparation, it can actually impact them. That's why we really do encourage families to kind of go to these birthing classes so they can really get mentally prepared for what's going to happen. You have these hormonal factors. Oxytocin is the hormone that is used during this to induce contractions. Sometimes mothers don't have enough going on themselves, so we do give them the medication Pitocin. It's also called oxytocin to kind of help them induce this. It's like they just need a little help. Prostaglandins themselves are the stimulants. It's going to stimulate the GI, some of the uterus, and these are the stress hormones themselves. Okay, onset of labor. This is a very important slide here. Probably we'll have a question on this. We do have, what makes a labor true and false? Pretty much the relation to this question, if you do get a question, it's like patients, at home, they're calling their doctor, they're saying, hey, I think I'm in labor, and they present these symptoms. Well, then it's like, you can still come in. But it's really all about what the answer is, because sometimes you don't need that. You don't have to come in, but sometimes you can also just play it safe and they can get an assessment, but it's probably not going to be true labor. Whenever it comes to these intervals, that's kind of the intervals of how often are the contractions, how often is the frequency of the contractions. Are they the intervals, are they kind of getting closer together, or are they staying long? Obviously, the entire process of the laboring process, it's getting shortening. The periods between contractions are getting shortened. So if it's staying long and nothing's happening, it's a false labor. If the intensity is increasing, it's getting more intense. I mean, it's just that's where it would be associated with a true labor, versus if it just feels the same. If it's like a Braxton Hicks contraction, then it would be a false labor. Where is the pain coming from? Is it in the back? Is it in the abdomen, in the front? If it's in the back, then it's more associated with a true labor. The real big one here is walking. What does that impact have on how you're feeling? Is it intensified by walking? Is it having no effect, or even giving relief? Cervical change, of course, thinning, effacement, all of that is going to be associated with true labor. But if they have no significant cervical change, then you're probably associating this with more of your practice contractions. And CONTX is what I use for contractions. Often usually before the actual, maybe a day or a week before they go into labor, they're going to have this thing called nesting, which is where they're suddenly very motivated to clean the entire house, get really ready. So I think I'm going to bird nest. It's really adorable. Wanting to, make sure that they have all the clothes laid out for them, getting the nursery ready, things like that. But it's really honestly adorable. Okay. We have these phases here. I have something I pulled from the book that is a little bit different, but these are our stages and phases. Recognize that we have 4 stages, but the first stage is made up of 3 phases. We kind of talk about how this is kind of changing the amount of centimeters. That's why I have it in parentheses. But the first one is going to be from 0 to 3 centimeters on that first phase of stage 1, early/latent phase. And then we get into the active stage of labor. Phase of labor, where it's a lot of course, a big change. We're going from 3 centimeters to about 7 centimeters. Once, they're excited, but then once those contractions are starting and it's changing a lot, she's getting really focused. And then around the transitional phase, it's of course 8 to 10. It is hyper focused. It is usually very painful, and they're more inward on ready to deliver. Of course, stage 2 is once we're starting the delivery of the baby. Stage 3 is it's all about delivering the placenta. After the baby is out, then we're next worried about making sure that placenta comes out successfully. Usually it's very smoothly. We don't have to tug on it. We don't have to pull on it. It will just come right out. And then after that is, they're going to cut the umbilical cord. And then it's all about making sure that that uterus is going through more contractions again to kind of, it's called an involution of the uterus. So, yeah. We do have the kind of things that we're going to be doing after stage 4 is completed, or I guess once it's started. We're going to assess the fundus. It's going to be reciting. We're assessing the fundus and vital signs every 15 minutes. And then after the second hour, we're checking every 30 minutes. The fundus is going to feel a certain way. You want it to be firm. If it's like really boggy and it's like squishy, then there could be bleeding present. I actually helped with the sim lab with OB, and that fundus on there was very boggy. So that's what it could be for you guys. The reason we're assessing this a lot is because during the first 2 hours, a postpartum hemorrhage PPH is the most complication. I mean, that's just postpartum hemorrhage, first thing, and postpartum hemorrhage be the word bleeding. Significant blood loss after is most likely to occur. And this is usually caused by whether it be like retained placenta fragments or anything like that. We have to be on the lookout. Postpartum hemorrhage is the number one thing that causes maternal deaths really throughout the entire world. We're very blessed here in our country that it's not as much, but we watched a documentary for a community for some other countries, and it's kind of crazy. It's like once they don't have access, sadly, to like lots of blood banks and things like that. So once they're going to hypovolemic shock, I mean, it's just, yeah, we're very blessed here. Okay. Assessment tools during labor, we have these, we have electric fetal monitoring. This is kind of when we're having, it's just, I don't know, computer assisted auditory and visual assessments. This is like whenever you're in the room and you're hearing their heart rate. That's kind of what that is. We have the external monitor. It's an ultrasound placed over the fetal back. It detects fetal movement, fetal heart. And I mean, think about it. It's like the gait belt. If our mother's obese, it could obviously interfere. Or even if it's just, sometimes it'll get altered and we have to reposition it. So I would say as an L&D nurse, don't freak out. Well, I'm going to put a little bit. I mean, if it suddenly changes, you can of course got to go and reposition, kind of like an EKG. We have the internal fetal scalp electrode. The word internal means, this is inside of the cervix. It is invasive. To do this, you must be at least 2 centimeters with rupture membranes, ROM will mean rupture membranes, and attach the epidermis of the presenting part. This provides the direct EKG of the fetal heart. So it's the internal, so inside the cervix, and it is going attached directly to the fetus to kind of give us like a little EKG. We have the IUPC, the intrauterine pressure catheter. We've got a pressure gauge on it. It's inserted through the cervix, past that first presenting part into the amniotic fluid of the uterus. Again, the same criteria. We have to be 2 centimeters with a rupture of membranes before this can be done. Now going into baseline numbers here. The fetal heart rate, these are the kind of numbers between contractions. Normal levels are going to be 110 to 160. Anything above 160 is fetal tachycardia. And anything below 110 is bradycardia. It's going to be really cool when you guys get to kind of assess the heart rates of newborns in the nursery. It's really cool. We have nitrazine paper. This is the paper that kind of assess. We're going to put, after they get a rupture membranes, we're going to assess to see if it actually was true. So this is the yellowish paper that will turn blue when it comes into contact with amniotic fluid. Kind of really cool. It's like, I don't know, I can't help but think of like, those papers you put on your face and it gets the oils off and it changes color, but it's kind of like that. We have the Leopold's maneuver. This is that palpation, that assessment that the doctor will do. They're going to place 2 hands on the uterus to determine the position and the possibly size of the fetus, also determine their lie. And then upon admission, we're going to need a CBC, a urine analysis. We're of course going to get a baseline of maternal vital signs. The status of the membranes, are they ruptured yet or are they not ruptured? Because if they're not ruptured, we might be having to do, we might have to rupture them for them, or we're just going to wait and then they're going to get it's called PROM, but it's a percutaneous rupture membranes. This is where we get the really cool term veal chop. It's already on the board here for us, but pretty much you're always going to want to write it out next to each other, VEAL and then CHOP. So variable Dcells are what can happen with or without contractions. Thankfully, with the V, it's going to be in the paper itself. Will look like a V or W shape. I'm going to go and show it real quick. This is what it will be. Kind of like a V or a W shape. As long as the baby can be recovered. If this happens, we can fix, but we're not too concerned. Like if the baby goes back with its heart rate, this can be okay. Usually this will be fixed with a position change or IV fluids if it is not getting better. Variable Dcells, like with the V, it's going to the C. Think of C as cord compression. The cord is just being compressed, and we, of course, if we reposition, it's gonna, if that's the problem, then it's just gonna be taking that pressure off of the cord, making it better, of course. We have early Dcells, not a bad thing if the labor is progressing, but this can be caused by head compression, usually associated with the vagus nerve stimulation from the head compression. It's usually uniform and it will mirror the shape of the contraction. Let me go and show a picture real fast. So it kind of mirrors it, and if anything, it's a little early, but the contractions down here, we have the increment, the acme, and then see how it's kind of going down a little bit earlier. So, and then of course, accelerations, that is okay. Okay. If the heart rate increases, 15 by 15, that's meaning that it's the greatest number of what's the number of beats changed from the fetal heart rate for 15 seconds. So if it's gone 15 up for over 15 seconds, then that's okay. If it is accelerating, we're not going to do anything. It's totally okay. If we get late Dcells, though, this is I would say the most severe one. Late Dcells is a placental insufficiency. So if we are not fixing this, let's say if we just choose to leave her supine or don't ever move her to the side or do anything, this is placenta, this is oxygen. If we don't fix this, then the baby could potentially get some brain damage, which would be not what we want. So the first thing we will do, like the person before, turn her on the side, usually left side, to increase the blood flow to the placenta. We're going to give IV fluids, oxygen, turn off the Pitocin. Pitocin is that oxytocin, so maybe this is happening because we are getting too much contractions. So if it is, if a contraction is coming out of like 45 seconds, then that wouldn't be a good thing. We have to we might actually give them some mag sulfate to kind of calm that down. But here we go. So the pictures, accelerations, you see how it's increasing, whereas the picture here is just decreasing. Their heart rate is decreasing and less oxygen is being really kind of given to the baby during that time. Late Dcells, we have the contraction, and then after the end of the contraction, the heart rate is just decelerating. Chances are you wouldn't have a picture, but I have a resource that we can actually practice some pictures because I wouldn't want to have it change and you guys get pictures, but we'll practice, it'll be okay. Okay, we have these baseline changes. The average fetal heart rate over a 10-minute period, kind of rounded to increments of 5. We have these different changes here. So if it is, if the kind of fetal heart rate isn't changing at all, that would be very concerning. If it's minimal, maybe it's changing by 5 or less. But obviously, as the heart rate is going about 25, then it's okay. 6 to 25 is good, and then marked, it's like, wow, they have some tachycardia. So we have to look at that. Remember, baby's heart rate should be 110 to 160. And usually our preterm infants are going to have the higher heart rate. Of course, bringing the patho in here, a variation of the baseline would indicate that the vagus nerve is well oxygenated. Cranial nerve 10. The assessment, we're looking at contractions. We're looking at fetal heart tones. What was their baseline? What is their variability? How often is it changing? Really just the whole veal chop? How is that going on? Are they having that? Usually in a test question, veal chop will be very evident to you. It'll say variable Dcells. It'll say all that stuff for you. The fetal scop stimulation, they might have to go in and stimulate them intravaginally. If the nervous system is intact, the baby should accelerate its heart rate after being stimulated. We could do a fetal fright test, startling the baby, increasing their heart rate, of course, causing accelerations. And when it comes to their kind of like an ABG of the cord blood gas analysis, this can't be done until the baby is out. So they'll take the cord, kind of evaluate it, give it a test. Once after the placenta is kind of out, they'll actually take, doesn't hurt at all, but they'll actually like take blood from the umbilical cord and of course test that, stuff like that. So that's kind of what that is. Okay, so we do have these cardinal movements here. This is the picture of this, but of course it is first descending into the pelvis. The amniotic fluid is just all around, and that pressure is increasing. The pressure of the funnus on the bridge of the fetus. Of course, even abdominal contractions. It's the straightening of the baby as it's going through the process. You know how they're all flexed and all tucked in. As they're descending to kind of fit, they're doing a reflection, of course, after that. But here's the picture. I'll go back real quick. They're flexed. They're going to do a flexion, and they're going to do their kind of rotations, kind of move to their way. Okay, next is the flexion. The fetal head descends and meets resistance from the soft tissue of the pelvis and the muscles of the pelvic floor and the cervix. Fetal chin flexes down onto the chest, and then it's going to internally rotate. The occiput rotates from left to right in order to fit the diameter of the pelvic cavity. And then it's going to straighten out, extend. The picture here. Their head's kind of coming back, as you see, extending. Oops, sorry. Their head is extending as it passes through the pelvis. Occiput, brown face emerge from the vagina. That'll be our presentation. So we can have an occiput, brow, or face. And then the shoulders of the infant. We're going to be, see, it's going to do an internal rotation. Coming out, like how their face is usually down, coming out, and the face is looking towards the left side. Of course, things can always change. We're kind of like talking about the perfect scenario here. And then the external rotation, the shoulders rotate after out, and the head is turned farther to one side. Expulsion, and then is the external rotation, pushing from the mom. The lateral flexion of the head and shoulder is born before the posterior shoulder. The body will follow. Very lengthy process. So kind of reviewing it, descending, flexing, internal rotation, flexion, extension, and then another external rotation as well. So the baby's out, and then of course we're then doing an Abgard score. The Abgard is kind of the first assessment of the baby. Really, this is just, they're given a score from 1 to 10, and we're doing this at 1 minute and at 5 minutes. This is the score of which will be used to determine if they need to go potentially maybe to the NICU, or if they are kind of chilling. And fortunate enough for us, it actually does go with the letters. So A would be appearance, kind of how, like, really just what color are they? Are their extremities blue? Is their chest blue? The baby kind of does a really good job of prioritization of oxygen distribution. So sometimes babies will be all pink in the head and chest, but maybe their arms are blue. And that's actually okay. That's called acrocyanosis. But if we saw a baby with, a blue extremities, blue neck, blue chest, then that would actually get a 0. Then we have their pulse. We have, of course, it's kind of using the 100. A 0 would be if it's less than 100. Then a 1 would be if it is, well, actually a 0 would be no pulse, sorry. Then if it is 1 point, it'll be if it's less than 100. And then of course, if it's A-okay, is if that pulse is more than 100. Then whenever it comes to grimace and activity, we're looking at their reflexes, kind of how their face is. Activity is kind of muscle tone, so how are their arms. And then of course, respirations, it's really determining how their cry is going. And we'll actually work on, I think newborn, this actually is more than a newborn lecture, so this will be next week, but we're going to be doing Abgards with test questions and stuff like that. So the baby should go on mom's chest afterwards. If everything's okay, maybe they get a 10 Abgard score. That means they're certainly okay to go ahead and get on the skin to skin, because pretty much after birth, think about it, you're in, we feel it all the time when we're in a pool, you're warm and cozy in the pool, even if it's hot outside. When that wind hits you when you jump out of the pool, you are cold. That's very much similar to them. So we want to make sure we're getting skin to skin contact. Our mothers are going to be usually 986 and sometimes a little higher. That'll always warm up our baby. But of course, before they go on the chest, we want to warm them. We want to dry them because we don't have evaporation taking all their heat, and we're going to stimulate them, of course. There is an exception if they need resuscitation. So if our baby, didn't have a pulse, or if they were not crying, crying is actually a very good thing after birth. If it wasn't crying, then the oxygen is just not being delivered. And of course, once the placenta is delivered, once stage 3 of our entire process is completed, we want to make sure that we're massaging the fundus. It's kind of the joke with OB nursing. It's like, when in doubt, massage the fundus. I tell you, I've seen that a lot, but really we're massaging it because we want to make sure that we're able to kind of reduce the bleeding a little bit, or kind of encourage it so everything can kind of get contracted. And we want to make sure that that fundus is really firm as we can get it. We do not want a boggy uterus. Okay, newborn safety. We're not in the 60s and 70s anymore. We're very good about this. I've seen on TikTok people talk about how it's like possible to swap babies, but it actually isn't. There's a huge system in place. Babies right after birth, they're going to get a band, and it will go kind of on their ankle. It'll be the exact same band that the mom gets. The baby must be identified before going into any, before pretty much going anywhere. So even if we know that that baby is that mom's baby, we have to confirm with their bands. We are going to make sure that they're staying warm. They're going to stay on their mom's chest. When they get those cradle caps, those really cute little caps, those aren't meant to just be cute. They're actually meant to keep them warm because we don't want them losing heat from their head. Of course, we're going to think about their airway. We're positioning them face down or a sideline on the mom's chest. With nutrition, we have to assess how the mom plans. Is she going to be breastfeeding? Is she going to be bottle feeding? Of course, really observing comfort, seeing how they're kind of just how the psyche of the mother after L&D. As they go into postpartum, we're looking, is she like really comforting? Are her hormones just kind of flaring, and maybe she's going through some like potential postpartum depression, really just different things like that. Okay, this is the actual Abgard itself. Pretty much this will be like every week that we kind of touch on this because it's probably going to be in your test. But of course, some of them are a lot easier. If it ever tells you a heart rate, it's dead on. It'll be just very simple. Absent, if it's less than 100, we're actually going to be giving them some CPR. And then of course, if it's more than 100, we're kind of okay because that's normal for a newborn. We've already talked about this, but the one that we didn't really hit on was muscle tone. Maybe they're flaccid, maybe their extremities are just moving a little bit, they're kind of flexing a little bit, or they just wobble and everything in their active movement of all the extremities. That would be that. The reflex, of course, grimace, as their face, are they really crying and they're doing a vigorous cry? They're pulling away when you're kind of touching them, or are they just doing a little bit of facial movement, very small and regular, very nonchalant about it. Okay. And then this was that last this was what I pulled from the textbook. This was a lot more detailed than what we had on the PowerPoint. But really, this is the different stages kind of respoken on, rather. We have 4 stages here. This is about, cervical dilation, delivery of newborn, delivery of placenta, and then of course, postpartum monitoring for bleeding. But this is really just a good resource talking about the different phases. And I screenshot this from your book, so it is in there. But yeah. And here is today's QR code again for those on the recording that haven't done it. And I believe it there. But let's go ahead and go into, I'm gonna stop the recording.